हेलो, लाइव हूँ, शुरू करूँ? A very good evening to you students. This is Dr. Vivek Goyal and I am Faculty of Medicine at DAMS. It gives me immense pleasure to introduce myself. Well, we were all fighting a very tough crisis, but with the help of our IT team and the enthusiasm led by Dr. Sumer and Dr. Deepthi, we, all the faculties, have enabled to reach out to all the students across the country and help you out even in these tough times. So I will be taking up nephrology in the next 6 classes, and I do know that cardiovascular, neurology and a bit of rheumatology also has been covered by the faculties. So it makes my work a lot more easier. So I hope you have all revised all the medicine that you've been taught already, and renal physiology must be on your fingertips, as I know that all of you have been studying really very hard and trying to motivate yourself up. So yes, I can see all of you are wishing me good evening. A very good evening to you as well. And we shall be taking up nephrology in the next 6 days. I shall wait for a minute for all of you to settle down. I hope you can all hear me clearly. Again, I can see the very common questions that have been staring at me since the past few days in my mail inbox as well. That, sir, I've attended your class previously. What should I do? I will strongly recommend you to attend my classes again and add on all the extra points to your previous notes that I will be teaching you henceforth. Okay? Yes, Anubhav Saxena, I will be teaching you right from the basics. Alright? So now, let us begin with the nephrology. So can you see this, guys? Again, wishing you all a very good evening, those who've joined late. I am Dr. Vivek Goyal and I'm a nephrologist, and I'm here to discuss with you nephrology. Alright? So, how's the Josh, Damsonians? How's the Josh? It ought to be high. It ought to be high. Okay? Alright. Now, before I begin with my subject proper, I would just like to motivate you all and myself as I do each day before I step on to do any new endeavor in life. And that is, I should realize, and you all should too, that behind me is an infinite power. Before me is an endless possibility, and around me is boundless opportunity. So it is the losers who say that there are no possibilities, there are no opportunities, life is dull, there are a lot of problems outside. But it is the winner's attitude that seek an opportunity and a possibility in every hardship even, and they beat the circumstance and emerge victorious at the end of it all. Okay? No, Divya Sharma, it ought not to be low. Now, the agenda that we have at hand is nephrology, and I have divided my subject into these 10 relevant subheadings, that is relevant anatomy and physiology, that is the basics of nephrology, clinical features of kidney disease, that is how does a kidney patient present to a physician, how do we investigate renal diseases, renal tubular acidosis, channelopathies, glomerular disorders, acute kidney injury, chronic kidney disease, hereditary and congenital diseases, and in the end, electrolyte disorders. Is it okay? Is it okay? Now, we shall now begin with the very first topic, as most of you have already suggested me that, sir, please start from the basics, because you know, as I always say, the crux of medicine lies in the basic physiology. If you do not have the physiology in your grip, you will struggle to understand the pathology and medicine. Yes, we all should be excited. Deepu Sharma is absolutely correct. Because if we do anything with lack of excitement, that will not make us successful. You know, it is a winner's quality to be zestful and excited at everything, no matter how small they are doing. And this is, of course, the biggest challenge of our life. Okay? All right. So, now, let us begin with the basic, let us begin with the very first module, that is the functions of kidney. We shall now discuss, that is, what are the functions of kidney. Now I shall slightly tilt the screen, okay? And the approach that I shall be adopting is that in between I shall be first writing and then explaining, and in certain topics I might first explain and then I might make you write. So do not at all think that sir has left something. I shall make it sure that each one of you is very special to me. Okay? As Deepti ma'am says, both the chota bachchas and the bada bachchas are very, very special to me, and I shall cater to each one of you. And I have designed the nephrology course so that you can complete your prof questions, you can make your MCQs, you can approach the MD entrance, that is the next exam, and even if many of you will be appearing for central institutes, that is PGI Chandigarh, AIIMS and JIPMER, everything has been included. So, if you thoroughly read the notes and if you thoroughly understand what I am trying to say, you shall absolutely get the point. Is it okay? Now, let us begin with the functions of kidney. So, I will just tilt this now. Yeah. So, the functions of kidney, you know, functions of kidney is such a basic question. It was asked in class 8, 9 and 10 also. It appeared in class 12 board exams also, and it is still haunting you when you are at the verge of entering your post-graduation. So such is the importance of this organ. Now, so what are the functions of kidney? You know, if this same question would have been asked to you if the same question would have been asked to you when you were in class 8th or 10th standard, you might have answered this. Am I correct? But if I ask you to consolidate, that is, what is the excretory function of the kidney? If I tell you in one basic word, it is excretion of metabolic waste products. It is excretion of metabolic waste products. What do I mean by that? It is mainly the excretion of urea, creatinine, uric acid, drugs and toxins. Yes, Sujata Kumari, you have to write with me only. Please start. I will be a bit slow. Keep writing with me and I shall be explaining along also. So these are the excretory waste products that are excreted by the kidney in the form of urine. It is excreted in the form of urine. Alright. Now, if the same question was asked to you at your MBBS level, when you would have got a bit more smarter, of course, you were smart before even, but yes, if you got a bit more smarter, what would you have said? You would have said, sir, kidney plays a very important role in homeostasis. What do you mean by homeostasis? In simple words, it means balance, striking a balance. You know, in life, striking a balance is very, very important. Sometimes we tend to do extra. If we do extra, we shall not be able to strike a balance and excess of things will accumulate in our body and will create problems for us. So what does it do? Kidney for us is a very, very good beam balance that maintains the homeostasis between water, electrolyte and acid base balance. So it maintains homeostasis, that is regulation of water, electrolyte and acid base balance. Okay? Alright. Now again, most of you have been asking me that sir, should I attend the class again? I am repeating it for the nth time and I hope that all of you will listen to me and you shall understand that yes, you should, because each day I promise to teach you something extra. I promise to become better and make you better in the process. So add the newer points that I have to tell you if you've attended my previous class. Now, it maintains water, electrolyte and acid base balance. Now, how does it do so? Now, in a very nutshell, it maintains water balance, but it requires the help of a very, very important hormone. Which hormone is that? My students tell me it maintains water balance with the help of, yes, you are correct, it is anti-diuretic hormone. It is anti-diuretic hormone. Okay? Is it clear? Yes, it maintains electrolyte balance. It maintains electrolyte balance with a very complicated process, but one hormone helps it in maintaining it, and that is aldosterone. That is aldosterone. Okay? And something about the acid base balance, which is very, very important. You know, acid base balance is very, very important. Now, let me tell you a bit about acid base balance. How does the kidney maintain acid base balance? Now, I will just be tilting it, flattening it a bit. Okay? Now acid-base balance in the body is maintained by three primary processes. Number one, the buffer system. Number two, the lungs. And number three is the kidney. Is it clear? Is it clear? Yes. So acid-base balance is maintained by three systems in the body, which are the buffer system, the lungs, and the kidney. Now, what is buffer? If in simple non-medical terminology, if I have to explain you buffer is basically something that will mediate or help the blood to not be altered despite there being a definite acid-base imbalance. So what is buffer? Buffer is that friend. It is that friend in the blood which will not let the blood pH to get altered despite there being a acid-base disorder in the body. So it is a very good friend to maintain the acid base. Now, a very important MCQ, which is a part of course renal physiology, which has been asked twice in the AIMS exam in the last 5 years, is the most important buffer system of the body is bicarbonate. The most important buffer system of the body is bicarbonate. Alright? The most important buffer system of the body is bicarbonate. Now what does bicarbonate do? What does bicarbonate do? Bicarbonate, it combines with the acid, that is the proton, and it forms CO2 plus H2O. Now this CO2 is eliminated by respiration. So what did bicarbonate do? It actually neutralized our acid. It neutralized our acid and did not let my H plus make my blood pH acidic despite there being protons in the blood. Is it clear to all of you? So a very important buffer in the body is bicarbonate. Now, coming to lungs, what do the lungs do? What do the lungs do? Lungs help in maintaining the acid-base balance by carbon dioxide excretion. By carbon dioxide excretion. Okay? Now, an earnest request from my side to all of you would be, you all are having a lot of personal chats in the live chat that I can see. Now, please refrain from having your personal short talks here, because it really hampers the concentration of other students. I know most of you are very, very serious here, so please try to follow me, alright? And if you do so, you will definitely benefit. Now, so how does the lung how does the lung help in maintaining the blood acid-base balance? Now, if there is metabolic acidosis in the blood, what happens? Metabolic acidosis leads to increase CO2 washout from the body. So what happens is, if there is metabolic acidosis, the person will hyperventilate and the CO2 will be washed out from the body, hence will lead to PaCO2 will fall. So the partial pressure of carbon dioxide in the blood shall fall, and it shall lead to a compensatory respiratory alkalosis. It shall lead to compensatory respiratory alkalosis. So this is how the lungs have enabled you to maintain the acid-base balance, and the opposite shall happen in metabolic alkalosis. What shall happen? What shall happen? In metabolic alkalosis, to counteract metabolic alkalosis, the patient will hypoventilate and CO2 will rise, the PaCO2 will rise and will lead to respiratory acidosis. Is it clear? All right. Now coming to the kidney. How does the kidney help in maintaining the acid-base balance? How does the kidney help? Now, the kidney excretes acid, and that is called as net acid excretion. That is called as net acid excretion. Now, so the third and the very important part of the kidney to maintain the acid-base balance is excretion of the acid, and that is known as net acid excretion. Now, what do you mean by the kidney's ability to excrete acid? What do I mean by that? Now, the acid that the kidney excretes, is basically 40% titrable acidity, 40% is titrable acidity, which is basically composed of phosphates. And 60% is composed, which is the most important form of acid secretion from the kidney, is ammonium ion. So if you are asked which is the most important way that the kidney excretes acid from the body, the answer shall be in the form of ammonium ion. It is NH4+. Now, how did the NH4+ come? It is basically due to the ammonia combines with the proton, forming the ammonium ion, and this ammonium ion combines with chloride to form ammonium chloride. So basically the acid in the body is directly proportional to proton in the body, which is directly proportional to chloride in the urine. Just try to understand this. This will be very, very useful. This concept shall be very, very handy when I shall teach you tubular acidosis. When I shall teach you renal tubular acidosis. So basically, what I have tried to explain you is that the kidney excretes acid in the form of ammonium ion, and ammonium ion combines with chloride to form ammonium chloride. So basically, the acid in the body is basically equal to the acid in the urine is basically the protons in the urine, and that protons in the urine is directly proportional to the urinary chloride. Very, very important. Very, very important. Okay? Okay? Is it clear? I hope it's clear to all of you. I hope it is absolutely clear to all of you. All right. I shall just give you 10 more seconds to copy this. So I'm just repeating it once again for you to revise and consolidate in your memory that that we were discussing the functions of kidney, and we have discussed the excretory function, that is formation of urine. Now we were discussing the homeostasis function. In the homeostasis, of course, regulation of water, electrolyte and acid-base balance. And in acid-base balance is maintained by three things, that is a buffer system, the respiratory system and the kidney. The buffer system is basically we are concerned with the bicarbonate. The lungs maintain it by carbon dioxide, and kidneys excrete acid. Kidneys excrete acid in the form of net titrable acidity, which is 40% comprised by titrable acidity, that is by phosphates, and 60% comprised by ammonium ion, which is basically urinary acid is directly proportional to urinary chloride. Okay, I hope I'm absolutely clear. I hope I'm absolutely clear, and this is an MCQ. This is an MCQ which is very, very important. Which is very, very important. Now, this just you might call it to be an physiology MCQ, but of course it pertains to nephrology. So I have taught you because this is neprophysiology. I hope I'm clear to all of you. I hope I'm absolutely clear. Yes, proteins are also a very important buffer. Proteins are also a very, very important buffer. Okay. See, you all know physiology, and physiology will be taught to you by ma'am also. But I hope you remember I am here to teach you the relevant physiology, which is very, very important pertaining to my topics right now, which definitely have an implied meaning in my diseases that I will be teaching you. Now, Bharti Gupta has been asking me what is titrable acidity. Now, titrable acidity are the weak acids that filter through the glomerulus and which can act as buffer. Clear? Titrable acidity means the weak acids that are filtered through the glomerulus, and which can act as buffers. I have repeated it to you. Okay? All right. Now, continuing with the functions of the kidney. We have already discussed excretion and homeostasis. Now we shall deal with the third function of the kidney. Okay. And the third function of the kidney, so as I was saying, a class 10th student would say excretory function, MBBS level student would say homeostasis, but if you go higher, you will also understand that the very important function of kidney is also some endocrine functions. So what are the endocrine functions of the kidney? Number one, the endocrine functions of the kidney are: number one, production of erythropoietin. Is it clear? Now, can you tell me which part of the kidney produces erythropoietin? Which part of the kidney produces erythropoietin? And the answer to this is, it is produced by the interstitial fibroblasts. It is produced by the interstitial fibroblasts in the cortex. So, erythropoietin is basically not produced by the capillaries, not produced by the PCT, not produced by the JG cells. It is produced by the interstitial fibroblasts in the cortex. This is a very important MCQ. Very important neprophysiology MCQ, mind you. Number 2. The second endocrine function of the kidney is activation of vitamin D. Is activation of vitamin D by production of the enzyme 1-alpha hydroxylase. 1-alpha-hydroxylase. And don't worry, I shall teach you the entire vitamin D metabolism while discussing CKD. So do not worry about that. Okay? I shall teach you the entire vitamin D metabolism when I shall teach you CKD. Now, so vitamin D is activated by 1-alpha hydroxylation. Last but not the least, it also has a very important role in maintaining the renin angiotensin aldosterone system, which we commonly abbreviate as RAS. So it also very importantly has a very important function in regulating the renin angiotensin aldosterone system. Okay, renin angiotensin aldosterone system, which we abbreviate as RAS. Okay, now what does RAS help us to do? RAS helps us to regulate blood pressure and GFR. RAS helps us to regulate blood pressure and GFR with a process known as autoregulation. With a process known as autoregulation. Am I clear? Am I clear to all of you? Superb. Okay. So basically, I'm just revising it once more for those who have joined late. That is, we've discussed the functions of the kidney, and the functions are excretion, homeostasis, and endocrine. The excretory functions are very, very important, as I will discuss henceforth also. Homeostasis, it regulates the water, electrolyte, acid-base balance, and in hormonal, it very importantly produces erythropoietin, which is produced by the interstitial fibroblasts. It activates the vitamin D by 1-alpha hydroxylase enzyme and the renin angiotensin aldosterone system, which regulates the blood pressure and the glomerular filtration rate. Alright, now after we have discussed the very basic functions of kidney, now let us in a very brief revise the basic parts of a nephron. As we all know that the functional and structural unit of a nephron, the functional and structural unit of kidney is nephron. The functional and structural unit of the kidney is known as nephron. So this is a nephron. Now if we quickly revise the parts of a nephron, it shall be very, very handy to all of us. Now, okay? Now quickly tell me what is the structure labeled 1? What is the structure labeled 1? 1 is, it is the bunch of capillaries, and 1 is basically, it is glomerulus. 1 is glomerulus. Okay? Now, this structure, which is encircling like a cup around the glomerulus, is nothing but Bowman's capsule, as you already correctly said. It is the Bowman's capsule. You need not draw this. Friends, you need not draw this. I will make a schematic diagram after this which you can draw. Okay? Now, the Bowman's capsule continues into a tubular structure which is known as proximal convoluted tubule. Which is the proximal convoluted tubule. You are absolutely correct, all of you students. Now, the PCT then continues into a U-shaped loop, which is known as loop of Henle. It is known as loop of Henle. This structure is known as loop of Henle. Is it clear? Absolutely clear? Superb. Now, as you can clearly see that the loop of Henle has a thin descending limb, a thin ascending limb, and the structure number 6 is very important to us nephrologists. It is very important to us nephrologists because this is the structure number 6 is the thick ascending loop of Henle. Thick ascending loop of Henle. Okay, this is the thick. This is the international abbreviation that is used. TAL or TALH. This is the thick ascending loop of Henle. Now, the thick ascending loop of Henle, as you can correctly see, if you can, continues into a structure which is known as 7. Which is known as 7, and it is really a brownie point question from my side. Let me see which student tells me what is the structure marked 7. Let me see who can answer what is structure 7. The structure 7, as you can see, is something, no, it is not DCT, absolutely wrong. It is something which is a part of thick ascending loop of Henle, and it is in close proximity to the glomerulus and the afferent and efferent arteriole, if you can clearly mention. And I have not seen a yes, very good, beautiful. And the 7th structure is something known as macula densa. The 7th structure is something known as macula densa. Is it clear? Is it clear? Very good. So tell me a basic nephroanatomy, neprophysiology MCQ which was asked in JIPMER exam. The question was, macula densa is a part of A. PCT of same nephron, B. PCT of the neighboring nephron, C. Thick ascending loop of Henle of the same nephron, or D. Thick ascending loop of Henle of the neighboring nephron. Which do you think is the correct answer? Which do you think is the correct answer? Can you tell me? Can you tell me? It resides in the thick ascending loop of Henle of the same nephron. Very important MCQ. It is a basic, but trust me, most students here only they falter. Okay? Alright. Beautiful. Most of you are answering correct. The crux is, ये same nephron का part है. It does not belong to the other nephron. Okay? Very good. Now, the thick ascending loop of Henle containing the macula densa now continues. If you can see, it now continues into this, which is the distal convoluted tubule. Which is the distal convoluted tubule. Okay? It is the distal convoluted tubule, and DCT now drains into a collecting duct. DCT now drains into a collecting duct which has two parts. One which lies in the cortex is known as, the part of the duct which lies in the cortex is known as cortical collecting duct. Which lies in the medulla is known as medullary collecting duct. I hope I have just tried to revise the basic nephroanatomy and physiology with you. There was nothing Greek or difficult that I have taught you till now. I am still in the revision mode so that you gather everything back from your medial temporal lobe, and we are absolutely set to study the diseases. Okay? Okay? I repeat, it is the glomerulus. I'm just repeating it. The glomerulus is surrounded by a cup-like structure, which is the Bowman's capsule, continues from the PCT, which continues to form the loop of Henle, which has a thin descending, a thin ascending, and a thick ascending loop. The thick ascending loop is very important to us nephrologists. The thick ascending loop continues to have the macula densa, which is in close proximity to the to the glomerulus and the afferent and efferent arteriole, which further continues to form the DCT, and the DCT drains into the collecting duct, which is in two parts, that is the cortical collecting duct and the medullary collecting duct. Alright, I hope I'm absolutely clear. Okay, now many of you intelligent students, let me give you some more trivia. Which some of you might not even know. PCT has three parts. PCT has three segments rather. PCT is divided into S1, S2 and S3 segments. PCT is divided into S1, S2 and S3 segment. Okay, and this part of PCT, the last part of PCT, which ultimately continues to the loop of Henle, is the S3 segment. This is basically the S3. So if I have to mark, this is S1, this is S2 and this is S3. Am I clear? Very good. And this, as I have already mentioned, is TALH. Now, just concentrate here, guys. I am going to tell you some applied anatomy and applied physiology, how it is applied in medicine and how you will be learning from it. Now, just see, this is the cortico-medullary junction. Can you see this? Above is the cortex, this is the cortex, and this is the medulla. Can you see this? So basically, there is a disease that I will be teaching you later on. And that disease is known as acute tubular necrosis, which is abbreviated as ATN. Please do not get worried. I will teach this to you later on. I am not teaching you ATN currently. I am just telling you the applied anatomy and applied physiology. Now, basically what I want to impress upon you is the fact, when tubular necrosis occurs, what happens is, the area which lies in the cortico-medullary junction, which is the watershed area of the kidney, suffers the most. Absolutely clear? वो एरिया जिसकी खुद की प्रॉपर ब्लड सप्लाई नहीं है, that area which does not have a proper blood supply of its own and lies in the watershed between the cortex and medulla, if at all there is a vascular jeopardy, of course that will be at stake. Please write this, what I am writing. Please write this. So if I ask you, which area of the nephron will suffer the most if ATN occurs? S is segment. If there is an ischemia, which area of the nephron will suffer the most? The answer is that area which lies at the cortico-medullary junction. Am I correct or am I wrong? So please, come on, correlate again. No, nothing to mug up. Please look here. Which area overlies the corticomedullary junction? It is the S3 and the thick ascending loop of Henle. So, a very important question, and in my knowledge, it is a very important prospective question for central institutes, that S3 segment of PCT and thick ascending loop of Henle is the most vulnerable for ATN. Is it clear to all of you? Please write down this part, write down that S3 segment of PCT and thick ascending loop of Henle are most vulnerable for ATN because they lie in the cortico-medullary junction, they lie in the cortico-medullary junction, which is the watershed area. I hope I am absolutely clear to all of you. Clear? I am repeating it once more. The S3 segment of PCT and the thick ascending loop of Henle, they overlie the cortico-medullary junction, which is the watershed between the cortex and the medulla, and that is why they are most vulnerable to ischemic injury if at all ischemia occurs. And that is why if there will be ischemia, the patient will have necrosis, and because it's an acute process, it is acute because it involves a tubule, because PCT, T stands for tubule. So that acute process which affects the tubules and leads to death of the tubules, that is known as acute tubular necrosis. Simple English, you can derive all the medicine from the word if you can. Okay? Watershed means above it has its own blood supply, below it has its own blood supply. Is it clear? Good. So these are the parts of a nephron, and the applied anatomy and the applied physiology and how to apply it in medicine. Very important MCQ, very important MCQ, and this is a very favorite type of MCQ which is very important for PGI Chandigarh. Such type of questions, of course, which are multiple correct answer type, and these conceptual anatomy but physiology derived, these are very important for PGI Chandigarh examination. Alright? Okay, superb. Now, okay? Now, you came across a concept which was auto-regulation. I told you the last endocrine function of the kidney is auto-regulation. Don't worry, I shall give you a schematic diagram. Do not worry, students. And that is nothing that you have not learned in physiology before. Okay? Okay? Now, what is auto-regulation? Now, before that, just to consolidate and give you a small schematic diagram, let me tell you this, that as if this is the afferent arteriole, this is the glomerulus, and this divides to form the, ultimately drains into the efferent arteriole. So, and here which is a cup-like structure surrounding the glomerulus, is your Bowman's capsule. So just let me mark it for all of you. Let me just mark it for all of you. This is your afferent arteriole, afferent with an A. This is an efferent arteriole. Efferent with an E. It has divided into a bunch of capillaries, which is known as glomerulus. Is it clear? Is it clear? All right, chalo. Some students are explaining, others on my behalf. I'm so glad and thankful to all of you who are playing my bit as well. Thank you so much. Okay. Now, many of you are asking me about the JG apparatus. All right. Now, we shall just discuss it in a very short bit. You know that the smooth muscle cell of the afferent contains some specialized cells known as juxtaglomerular cells. Just a second, guys, just a second. Yeah, thank you. I'm so sorry, the charger of the laptop had just tippled over. So, these are the juxtaglomerular cells, which are abbreviated as JG cells. This lies in the afferent arteriole. These are specialized smooth muscle cells in the afferent arteriole, afferent for A. Alright. Now, here, in very close proximity to the afferent, efferent and the glomerulus lies a specialized sensory organ. If you remember, which I had shown you in that figure. And please tell me what is the name of the sensory organ, all of you quickly. Please draw this figure also with me. And this specialized sensory organ is known as macula densa. Is known as macula densa. Is it clear? Now, also I'm so sorry. Yes. Yeah. So, this is the macula densa, the JG cell, the macula densa, and here in the extraglomerular mesangium lies some supporting cells which are known as lacis cells. Which are the lacis cells? Lacis cells. Okay? So these form the juxtaglomerular apparatus, that is the macula densa, the JG cells and the lacis cells. Now if some of you have already seen, I have drawn, if some of you have noticed till now, I have drawn the afferent to be much wider than the efferent. What do you think? It is a drawing mistake or it is deliberate? What do you think? It is a drawing mistake or it is deliberate that I have made the afferent much wider or having a bigger lumen than the efferent? What do you think so? Why do you think so? See. Yes, they are extraglomerular mesangial cells. Absolutely correct. Now, just listen to me. So if I was, yes, you are correct, it's deliberate. So if I am to take a class in a big stadium where I want all the students of the country to come and listen to me and study nephrology with me. Then what shall I do? What shall I do? I shall make the entry gate of the class very big and I shall make the exit gate very small. ये exit बंद ही कर दूंगा. So what will happen? All of you will enter the classroom, but nobody will leave the classroom. Some naughty students are like, sir, we will leave through the entry gate. But no, I will make a darwan sit there. Nobody will go from there. So what will I do? I will make the entry wide and the exit narrow. So all of you will enter the class, but nobody will leave the class. So more of you will sit in my class and there will be more percolation of knowledge. Yes or no? Yes. So similarly, if I want more filtration to occur, what will I do? I will make the entry gate wide. Entry means afferent, and I will make the exit gate small, so more blood enters the glomerulus, less blood leaves, more blood stays here, and there is more and more and more ultrafiltration. Is it clear? Is it clear? So basically, just write it down. There is dilated afferent arteriole and constricted. Please don't confuse with afferent and efferent. Arteriole. So what will happen? It will lead to, if I am now talking in medical terms, it will lead to increase glomerular hydrostatic pressure, and increased glomerular hydrostatic pressure will lead to increase urine formation. So this is the importance. This is the importance of the afferent arteriole to be wider. So afferent arteriole is dilated, the efferent is constricted, so more blood enters the glomerulus, less blood leaves, there is increased glomerular hydrostatic pressure and there is increased glomerular filtration. I hope I'm absolutely clear to all of you. Am I clear? Am I clear to all of you? BC is Bowman's capsule. It is Bowman's capsule. Now, please tell me which is the structure, what is the structure that helps me maintain my wide entry gate? वो कौन है जो मेरे entry gate को पकड़ के खड़ा है and that is saying that I will open the entry gate wide so that all the blood will enter the nephron. Which is the substance that maintains the dilated afferent gate? And the substance which keeps the afferent arteriole dilated is prostaglandin. Am I clear? So prostaglandin is responsible for dilating my afferent arteriole. And which is that structure which constricts my efferent arteriole, which has kept my efferent arteriole to be constricted? Which is that structure? Come on, tell me, students. So my afferent arteriole is dilated, my efferent arteriole is constricted due to which structure? And the structure is angiotensin II. The structure is angiotensin II. So afferent arteriole is dilated by prostaglandin and efferent arteriole is constricted by angiotensin II. Now, can you tell me by your common sense one substance that will inhibit the dilatory action of prostaglandin? Can you tell me? Can you tell me by your common sense one substance which will constrict my afferent arteriole? Yes, you are correct. That substance which will inhibit the prostaglandin, that is NSAIDs. that is NSAIDs, will constrict my afferent arteriole because it is a prostaglandin inhibitor. Absolutely correct. Absolutely correct. And that substance that will dilate my efferent arteriole. Can you tell me one substance that will dilate my efferent arteriole? That is the inhibitor of angiotensin 2. That is ACE inhibitor or ARB. Am I right or wrong? Am I right or wrong? Yes, you are absolutely correct. So NSAID will inhibit the afferent arteriole dilatation and ACE inhibitors ARB will inhibit the efferent arteriole constriction, and both of them will lead to fall in GFR. One will reduce my entry gate and one will widen my exit gate. So many naughty students will not enter my class, and some more naughtier students having entered will exit my class. In short, less knowledge will be percolated. In short, less of urine formation will occur. Yes or no? Super. Now, let me say that already many of you are having vacations only. So tomorrow morning, and you were sleeping soundly in your bed, and at 6 a.m. your nagging neighbor auntie rings the bell. Most of you, all of us have a nagging neighbor auntie who creeps up at any point of time of the hour asking for sugar and salt. So say for example, your nagging neighbor auntie rings the bell at 6 a.m. in the morning tomorrow. Your mom opens the door and she's like, "Ma'am, I'm having really a lot of headache. Your daughter or son is a doctor. So ma'am, please help me, ma'am. Please help me. Please wake him up." And your mom wakes you up and tells you that, "Beta, go. The nagging neighbor auntie has come to you for a medical consultation." You immediately wake up. And you go there and she tells you, you were already asleep. And your nagging neighbor auntie tells you that, "Beta, please help me. No, I am having a lot of headache." Suddenly you are reminded of that one emergency that which you attended during your you went to a casualty in your hospital. And you had heard your seniors saying that, "Beta, if ever somebody elderly has a headache, please measure the blood pressure. So you decide, let me do something. You go to your room, take out a brand new sphygmomanometer, a brand new stethoscope, and tell auntie, "Please sit down, give me your right arm." And you measure the blood pressure. On measuring the blood pressure, very mechanically you tell her that, "Auntie, your blood pressure is 160/90 millimeter mercury." She, as a layman, also understands that BP is definitely high. And after uttering the BP, you understand that BP is high. As soon as you tell her very confidently that, "Auntie, I have diagnosed your problem. You are having headache because of high BP." Now she throws a googly at you. She tells you, "Beta, now that you have diagnosed my condition, please also treat it." The moment she utters this sentence, you start having palpitations now. And 5 seconds later, you tell auntie that, "Auntie, please, I'm coming from the washroom." You go to the washroom, but did you go to pee? Of course you didn't go there to pee. You went there to check Google. And again you see network is not working. And suddenly you try to flip across the pages of KD Tripathi in your mind. And randomly one drug comes and hits your brain and you are reminded of telmisartan. But again you are in despair because KD Tripathi didn't have the doses written properly. So you still remember telmisartan, but you don't know the dose. So now you're checking for the Wi-Fi and the 4G network, and somehow you manage to have the network, and you type on Google, "telmisartan dose." And thankfully, Dr. Google tells you and prompts you 40 milligram. Immediately you have a wide smirk on your face. You step out of the washroom, go to your room, take out a blank piece of paper and write on it, Mrs. Nagging Neighbor Auntie, age 55 female, RX, tablet telmisartan 40 mg once daily into continue, and the first autograph of your life. And you hand over the paper very, very confidently to the auntie. And then, in a very dim voice, she tells you, beta fee? Beta consultation fee? As soon as she says this, in your heart and in your chest, all the laddus have already started to fato. You always waited for this day. You bloody entered this profession for this very day. But, how could you? How could you? You tell her, no, auntie. I'm just like your son. I've grown up with your son Bunty. I've played cricket with him. How can I charge you? But in your mind you are saying, please give me, at least give me $100. I'm happy with that. But of course she also didn't want to give you. She was just trying to, be very genuine with you. And she goes away. You go back to your sleep very confidently. You are so happy that you have treated the very first patient in your life. Cut to 7 days later, again that nagging neighbor auntie rings your bell. But now the bell has a lot of vigor. It is ting tong, ting tong, ting tong, ting tong. Your mother opens the door, and now the auntie says, bring your son, bring your daughter. Your mother is worried. Your mother is worried. Your mother calls you. Chalo beta, chalo, auntie's come back again. She wakes you up. She tells you, beta, auntie is very angry. Come again, come again. You are half asleep. You are rubbing your eyes. And now she's charging at you that, what did you do to me? She said, what happened, auntie? I treated you. She was like, no. I was feeling very, very, not so well. And I don't have any work. So I got myself a routine blood test done. And last month also I did not have any work. So last month also I got a routine test done. And last month my serum creatinine was 1 mg per dl. And this month my serum creatinine is 1.25 mg per dl. And I've read in Dr. Google that creatinine is a marker of kidney function. And rising creatinine means decreasing kidney function. In short, you have decreased my kidney function. Because last 1 month में मेरे साथ एक ही चीज बुरी हुई है, that is having your drug. In short, you have ruined my kidneys. In short, you have killed me. You were almost still asleep, still in your REM sleep, and your auntie shook the entire neurons of your body. At this point, you can do 3 things. Either you can tell her, you can, shout at her, be angry. No, auntie, I didn't do anything. Go from here. एक तो आपको treat करो and you're charging back me again. And if your father is very rich, you can tell her, auntie, don't worry. So what if your kidneys are bad? My father is rich. I'll get you a kidney transplant done. And the third one, if you're my student and if you attended my class, this class of mine, what shall you do? You shall take a pen and paper and you shall draw this diagram. You shall tell auntie that, auntie, this is the afferent arteriole, this is the glomerulus, and this is the efferent arteriole. Your efferent arteriole was constricted by angiotensin 2. But I gave you a drug to treat your BP, which was a telmisartan, which is an angiotensin receptor blocker. An angiotensin receptor blocker inhibited the constriction of efferent, that is, it dilated the efferent. So more blood left the efferent. In short, your GFR fell down. And because your GFR fell down, your serum creatinine rose. In short, auntie, after giving ACE inhibitor or ARB, rise in serum creatinine to a certain limit is normal. In fact, auntie, if your creatinine had not risen by a bit after ACE inhibitor ARB, that could have meant that I have underdosed you. So auntie, please जाओ, सो जाओ और मुझे भी सोने दो. Have you understood? Have you understood? Why did I tell you? I see so many juniors of mine, interns, or even a first year postgraduate resident telling me, sir, what happened? Sir, I'm very afraid, sir. I prescribed telmisartan or ramipril to a patient, sir, and his creatinine has risen. I said, by how much? By 20%. So what? It is bound to rise. Is it clear? So I hope that this does not happen with you in real life, and you have the basic concept of nephrology and medicine together. If you have it, my friends, you are never going to be confused. So that is why always have physiology in your grip. Chalo. Okay? Now, so we have understood today with our nagging neighbor auntie that ARB will lead to fall in GFR, Baba. It will lead to fall in GFR. And GFR fall means rise in creatinine. But I will not worry. बहुत बढ़िया. चलो. Now, many of you were asking me about the schematic diagram that I was to draw for you. So now, chalo, let me cater to all of you. Let us draw a schematic diagram and understand the physiology much better. So, if this is a Bowman's capsule which is continuing as the PCT, if this is the loop of Henle which now continues to have the thick ascending loop of Henle, ultimately becomes the DCT and ultimately drains into the collecting duct. Okay? Please pardon my diagram. This is not an Ichhadhari Nag. This is not an Ichhadhari Nag, nor is it King Cobra. It is the schematic diagram of a nephron. Please bear with me, okay? This is not a anatomically very sound diagram, but yes, it is a schematic diagram. Okay? Now, and I am not labeling it once more for you because you already know that. How to label it and what are the parts of it. You already know that. Now, okay? Now, if this is the aorta, wait just for a second. Yeah. So if this is the aorta, now you know that the aorta gives rise to the renal artery. The aorta gives rise to renal artery. Renal artery divides to form the, come on, let us revise. The renal artery divides to form the interlobar artery. Interlobar artery gives rise to form the, so sorry, I'll not fit into this space, so I'll have to shift more on the right. So sorry. If this is the aorta, this is the renal artery, this is the interlobar artery. Interlobar artery divides to form the arcuate artery. Arcuate artery divides to form the cortical radical arteries, and cortical radical artery से आया आपका afferent arteriole, which continues to form the glomerulus, which is a bunch of capillaries. Yes. Okay. This is your afferent arteriole. This is your efferent arteriole. Yes, you have to draw this. I am drawing it for you. A very simplistic diagram. Please draw this, all of you. Please draw this, all of you. This is the Bowman's capsule. This is the proximal convoluted tubule, and here something lies the PCT. Something like this is the PCT, proximal convoluted tubular cell. This is the cell. Here lies the thick ascending loop of Henle. This is a cell and this is the lumen. This is the DCT. This is the collecting duct. So this is the cortical collecting duct. And cortical collecting duct has two types of cell. One is the principal cell and one is the intercalated cell. One is the principal cell, one is the intercalated cell. And this is the medullary collecting duct. Medullary collecting duct. Something like this. Okay? Alright. This is the principal cell. First draw all of you, then I will explain to you. This is the intercalated cell. MCD is for medullary collecting duct, CCD is for not Coffee Cafe Day, it is for cortical collecting duct. Yes, Diksha, you are correct. You should listen to teachers more often, you know. So this is how it works. Now basically, if you can just tell me how much is the cardiac output? How much is the cardiac output? Cardiac output is approximately 5 liters per minute. Out of the 5 liters, the kidneys receive 20 to 25% of cardiac output. Yes or no? Yes or no? Kidneys receive 20 to 25% of cardiac output, which is basically 20% of 5 liters. What does it mean? What does it mean? It means 1 liter per minute. Now it is 1 liter per minute of blood, mind you, and blood is composed of 60% plasma and 40% cells. So basically, can I say that the renal plasma flow is 60% of 1 liter, which is basically 600 ml per minute? Yes or no? Mind you, I have already discussed 3-4 MCQs with you. This is an MCQ and this is an MCQ. This also is an MCQ. So I am repeating it once more. 5 liters per minute is the total cardiac output per minute, out of which kidney, I mean both the kidneys, mind you, both the kidneys receive 1 liter per minute blood, which means 600 ml of plasma per minute. Now come back here. So if we have to understand this concept properly, just look here, all of you. Let me use a different color. Yeah. So approximately through the afferent arteriole, 600 ml per minute of plasma comes. Am I correct? Out of the 600 ml per minute plasma, only 120 ml per minute gets filtered, which is the GFR. So basically, just understand the kidneys received simultaneously 1 liter per minute blood, of which 600 ml per minute plasma flew through the glomerulus. Excuse me. Now from the glomerulus, out of the 600, 120 ml per minute of fluid got filtered through ultrafiltration from the glomerulus into the Bowman's capsule. It flew into the tubule, so underwent many processes, and ultimately came out through the collecting duct as urine. And how much urine does a normal person usually form? Normally it forms 1 ml per minute urine. So just try to understand the beauty, of our kidney. It will receive 1 liter of blood, that is 1 liter of blood, which is effectively 600 ml of plasma per minute, and ultimately will form only 1 ml per minute of urine. So 600 ml entered, 120 filtered, and out of 120 ml, only 1 ml per minute came out as urine. And you know that these cortical collecting ducts, where do they drain? The medullary collecting duct and the cortical collecting duct, they drain into the minor calyces, which drain into the major calyx, and which ultimately drains into the pelvis of the ureter, which drains to the ureter से bladder से urethra, और urethra से आपका pot. So just see how have we traversed the journey from aorta to your pot. Can you understand what I'm trying to say? Can you understand? I'm meaning for both. Dipali Shukla, I mean 1 ml per minute is for both the kidneys. I will just recapitulate it once more. The aorta forms the renal artery. Renal artery forms the interlobar artery, which divides into arcuate artery. Arcuate artery becomes a cortical radical artery. The cortical radical artery forms the afferent arteriole. It is also a question asked in MCQ exam. Afferent arteriole is a branch of cortical radical artery. The afferent arteriole divides into a bunch of capillaries, which is known as glomerulus. This glomerulus continues as the efferent arteriole. Now, 600 ml of plasma entered the glomerulus, out of which 120 ml got filtered. It underwent a lot of processes, and ultimately 1 ml per minute of urine came out, which passed through different calyces and ultimately exited your urethra to enter into the pot. Am I clear? Beta, pelvis of ureter से ureter से bladder से urethra से wherever you wish to. Okay? So this is how the urine formation occurs. Is it clear? Now, thick ascending loop of Henle, TALH, Dhwani Joshi. I hope you have all drawn this figure by now. Good. Very good. I will just wait for 5 more seconds so that all of you can copy it down. Okay. Now let me give you one more interesting concept. You know, I've studied many a times, but maybe you have not visualized this. I want you to visualize both in macro and micro level. Now this efferent arteriole now continues to form the peritubular capillaries, and the peritubular capillaries then continues ultimately to become venous, and ultimately that becomes a renal vein and drains into the IVC. So these are Peritubular capillaries. These are peritubular capillaries. How to calculate RPF will be taught by physiology. Okay, that is not my domain. So these are peritubular capillaries. So afferent becomes glomerulus, glomerulus becomes efferent, efferent becomes peritubular capillaries, and ultimately continues to be the venous side, which ultimately drains to the IVC, that is inferior vena cava. All right. Now, moving ahead. So basically, if I have to just so if this is the schematic diagram of the nephron, just try to understand this. यहाँ से from the glomerulus something entered your Bowman's capsule. This process was known as ultrafiltration. Okay. Now this, I told you, becomes a peritubular capillaries, and it continues all around the tubules. That is why it is known as peritubular. ठीक है? Peritubular का मतलब क्या है? It is surrounding the tubules. Now, so first process is ultrafiltration, where the blood passes from the glomerulus against a pressure-driven process. This is a pressure-driven process that continues from the glomerulus into the Bowman's capsule. The next process is, now look here. Now it might so happen that some substances have come onto the urine which should not have come, or which is still relevant to the physiology of your body. For example, sodium. For example, glucose. So you want them back. To want them back, what will your body do? Your body will reabsorb them from the urine, from the fluid, back into the cell, and from the cell back into the blood. Can you see this? Can you see this process? We simplistically draw from the urine to the blood, but actually it happens in a stepwise manner. It happens from the urine to the tubular fluid, to the cell, then to the blood. And this process, where things are reabsorbed back, is known as reabsorption. This is known as reabsorption. Now, there might be still an opposite process. There might still be an opposite process which does the opposite of reabsorption, that is, secretes the substances which you do not want in your body. Which you do not want in your body after all this has occurred. And actually, practically, that takes place throughout the nephron. And that is basically from the blood into the urine, from the blood into the urine. And if I draw the blood capillaries here also, it will go from the blood into the urine. And this process, where things are going from the blood into the urine, is known as tubular secretion. This is the third process. This is the third process. This is the third process. So basically, the urine that you have is the end result of three important processes that are functioning in your nephron, which are ultrafiltration, reabsorption, and secretion. Is it clear to all of you? Is it absolutely clear to all of you? Now what we shall do is, this was a macro level looking in the nephron from a distance. Now we shall magnify the lenses of our eyes and we shall zoom into each individual cell. And today I shall teach you a very novel approach. I shall teach you how to integrate physiology, with anatomy, with pharmacology, with medicine, with pathology, with pediatrics, and with genetics. So this next 1 hour is going to be the epitome of integrated learning. Okay? This is going to be the epitome of integrated learning. How? See. What am I going to do? Just look here. Just look here. So this we have studied is a PCT cell, right? This is the PCT cell. This is the thick ascending loop of Henle. This is the DCT. And these are the cortical collecting duct cells. So now we shall study each cell in detail. Can you see this now? Can you see this now? You have to please draw this. You have to please draw this figure along with me. My dear students, class is till 10:30. Class is till 10:30, my dear students, okay? Not till 9:30. So, please, please bear with me. It is going to be very interesting, and you'll have to learn. You'll enjoy learning a lot. Okay. So what is this? Can you remember my last diagram? Can you remember my last diagram? I'm focusing you once more. We were discussing this. We were in this diagram. This PCT. And right now I'm just going to zoom this PCT. Okay? So this is the zoomed PCT. This is the zoomed PCT. Alright. Now, this PCT is zoomed now, and please draw this diagram with me, all of you. Please draw this diagram with me, all of you. Now, as you can clearly see, the PCT, this is the lumen of the PCT. So here, from here, urine was coming. And this is the blood of the peritubular capillaries, if you remember. Alright, guys, please stop cribbing. We are all here to learn. We are all stretching our limits. And you know, learning has no end. Okay, dil dhak dhak mat karo. You are all viewing this over your phones and tablets. So you can jolly well have your dinner, eat something, have a munch while doing this. Okay? It is me who cannot eat while taking the class, but you all can. And if you needed my permission, I have given you my permission. Okay? Alright. Now please see, please draw this diagram, all of you. Please draw this diagram, all of you. Okay? This does not look, this is not as complicated as you think it to be. And I'm repeating it once more. It is a very schematic diagram. Now, in the luminal aspect of PCT, there is a very important channel known as sodium glucose co-symport, जिससे क्या अंदर जा रहा है? Sodium and glucose are being reabsorbed. Actually, glucose is being reabsorbed, and with the help of which sodium also as a byproduct enters inside the cell. Now, all you pharmacology champions, can you just think and tell me if this channel is inhibited? If this channel is inhibited, will glucose be reabsorbed? Will glucose be reabsorbed? Yes or no? No. So glucose will be lost in the urine. So can I use this channel to treat a disease known as diabetes? So that glucose is decreased in my body, more glucose passes to the urine, and my diabetes is treated? Yes. So can you tell me the name of the drug which is used to treat diabetes through this channel? It is SGLT2 inhibitor, which is the empagliflozin or the canagliflozin. Superb. Very good. Now, the next channel, as you can see, is a sodium phosphate co-transport through which sodium and phosphate is reabsorbed. This is the phosphate ion. Now, can you tell me which hormone inhibits this channel? The hormone that inhibits this channel is known as parathormone. It is known as parathormone. You must have read it earlier also, and I will also teach you while teaching CKD that the principal phosphate-uric hormone in the body is parathormone. So what do you mean by phosphate-uric? That secretes phosphate inside the urine. So PTH is the phosphate-uric hormone that excretes phosphate in the urine. Now, coming to, I'm pretty sure which was not taught in your physiology class. Now, let us integrate this with genetics and with pediatrics and with biochemistry. The next channel, as you can see, is reabsorbing amino acids from the urine into the cell and from the cell into the blood. Dapagliflozin, canagliflozin, empagliflozin, all the gliflozins. So the next channel is amino acid. Amino acid being reabsorbed. और इस चैनल का नाम है SLC3A17A9. See, the disease I am going to tell you right now, all of you have heard the disease name, but you have not correlated it and you have not visualized it. See, my students, our mind is such, it thinks in figures. It does not think in alphabets. When I say an apple, what does come to your mind? APPLE or a round color red fruit? It is a red fruit. But when I say cystinosis, what comes to your mind? CYSTINOSY. Because you have not been able to visualize cystinosis. So by the mean of this diagram, why am I giving? I would have made you write in theory only. I am giving you this diagram because I want you to visualize the disease. So when I say SR disease, you can directly visualize this photograph and you can remember everything. The second channel is sodium phosphate co-transport. So this channel, if has a lot, before that, just I'm telling you two terminology which I shall be using very often. That is loss of function. I shall write as LOF, and gain of function I shall write as gain of GOF. Okay, and hashtag will be used for mutation. This is not an international terminology, this is my terminology for writing in a small space. So GOF means gain, loss of function means LOF, and mutation means hashtag. So if this channel, which is SLC3A17A9, undergoes a loss of function mutation, what will happen to this disease? What will happen? The amino acids will not be reabsorbed, and the amino acids will not be reabsorbed. There will be amino aciduria, and that disease is known as cystinuria. नाम तो सुना होगा? Yes or no? You definitely have heard it, but you have not correlated it. So now, if in biochemistry paper you are asked, cystinuria is due to mutation of, you will quickly tell me, you will remember from my nephrology class that sir had told me it is due to mutation of SLC3A1, SLC7A9. These are the two channels. SLC3A1 and SLC7A9. Yes? And can you tell me, my biochemistry champions, what is the cystinuria due to? I mean, what does it lead to? It leads to loss of, yes, cola, cysteine, ornithine, lysine, arginine. This was the mnemonic, when I was an MBBS student, I used to remember by this only. Okay. All right. Superb. Now, the next channel that we have at hand is a chloride channel which goes by the name ClCN5. 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 This is a chloride channel, and if this channel gets mutated, if there is a loss of function of this channel, can you tell me which disease will occur? You will definitely study that disease in pediatric class, and this disease is known as Dent's disease. This disease is known as Dent's disease, and let me tell you, it is a favorite topic of PGI Chandigarh and AIIMS. This is a favorite topic of PGI Chandigarh and AIIMS, and this is an X-linked recessive disease. It is characterized by low molecular weight proteinuria, CKD, hypercalciuria, and rickets. These are the 5 MCQ points which are very, very important for Dent's disease. And the gene responsible is ClCN5. ClCN5. Please do not try to beautify the diagram. Just make a schematic diagram. Make an arrow, write down SGLT2. Make an arrow, sodium phosphate cotransport. Like that. And write down the name of channels which are important. Okay? Beta, information, Ankit Kumar Singh, information is everything. You know, but random information is available everywhere. But when you process it with understanding and concept, it becomes knowledge. So information is available everywhere in the market. And in today's place, you don't need to go anywhere to gather information. But to create concepts and knowledge, this is why you have come here. And DAMS is the epitome of providing you concepts, because concept-based learning is what will take you far. Okay? So this is about Dent's disease, which is ClCN5 mutation. Okay? Which is a chloride channel. It's a chloride channel. ClCN5. Now. Alright. Okay? Now, another very important thing I want to tell you is that any doubts still I will cater in the last. Don't worry at all. I am here for you all. Don't worry. Okay. You must remember that with the help of an enzyme which is carbonic anhydrase 2 enzyme, bicarbonate is reabsorbed through this channel. Sodium bicarbonate cotransporter. Sodium bicarbonate cotransporter, which is a hypercalciuria. Before rickets, I have written hypercalciuria. XLR means X-linked recessive. X-linked recessive. So with the help of carbonic anhydrase 2 enzyme, bicarbonate is generated in the PCT and it is reabsorbed through a channel which is sodium bicarbonate cotransporter on the basolateral aspect. Am I clear? So, मान लो that this channel does not function. This has a loss of function. This channel has a loss of function. So what I'm trying to tell you is, if this sodium bicarbonate channel, sodium bicarbonate cotransporter, suffers a loss of function, so it is not working. So what will happen? What will happen is bicarbonate will not be reabsorbed. Bicarbonate is an acid or base? It's a base. So base will not be reabsorbed. If base is not reabsorbed, body में क्या होगा? In body, Ca2 means carbonic anhydrase 2. If base is not reabsorbed, it will develop acidosis, correct? And What organ are we studying? Kidney or liver? We are studying kidney. So it is acidosis due to renal. And which organ of the renal is involved? It is the PCT. T for tubule. T for tubule. So if there is a loss of function, there will be a disorder which is an acidosis. Because we are studying kidney, it is renal. And because it involves the PCT for tubule, it is tubular. So basically this is renal tubular acidosis. This is renal tubular acidosis. So many of you have been messaging me, sir, one topic I failed to understand in nephrology is RTA. Do not worry, I will explain you in the simplest language. So basically, if this channel is hampered, you develop RTA. And which type of RTA is this? This is RTA type 2. Or because it is a defect of proximal convoluted tubule, this is also known as proximal RTA. This is also known as proximal RTA. Okay? Okay? Don't worry. When I will discuss RTA, all your remaining concepts will be absolutely clear. Do not worry. So bicarbonate loss means base loss means acidosis, acidosis means kidney acidosis, and why kidney acidosis? Due to tubule, so it is renal tubular acidosis type 2 or proximal RTA. Superb. Superb guys, superb. Beautiful. All of you are absolutely amazing. Now, just do me another favor. Make an arrow here और एक साइट्रेट को अंदर जरा डाल दो ताकि आप लोगों को ये याद रह जाए, so that you remember that citrate is reabsorbed through PCT. Citrate is reabsorbed through PCT. So we have understood that citrate is reabsorbed through PCT. Okay? All right? No beta, I am not at all joking. Class is till 10:30 and not only today, but for the next 6 days only. Yes, Deepthi Agarwal, I will make you a nephrologist by the end of 6 days. If you are with me and you are concentrating with me, I can tell you for sure that you will develop a love for nephrology. Okay? Okay? Now, come to thick ascending loop of Henle. Acha, before this, let me give you one more concept. So you understood that this is the PCT, and through PCT you were reabsorbing glucose, you were reabsorbing amino acid, you were reabsorbing phosphate, you were reabsorbing bicarbonate, you were reabsorbing citrate and what not. Yes or no? Yes. मान लो this entire PCT is malfunctioning. So if there is global PCT dysfunction, if there is global PCT dysfunction, what will be the presentation of this disease? Very easy, sir. सबके आगे यूरिया लगा देंगे. So this will present as glycosuria, phosphaturia, bicarbonate urea, amino acid urea, citrate urea, and etc. Just add urea in front of it. Yes or no? So do you know which disease have you already studied now? आपने इस डिजीज का नाम बहुत बार सुना है. You have heard it a lot many times, but you do not know that this is this disease, because You have not picturized the disease. I always tell you, picturize the disease. And this disease is known as Fanconi syndrome. नाम तो सुना होगा, नाम तो सुना होगा. This is Fanconi syndrome. So if somebody asks you, what is Fanconi syndrome? So simple, sir. Fanconi syndrome means global PCT dysfunction, which is characterized by glycosuria, phosphaturia, bicarbonaturia, amino aciduria, citraturia, and so on. Super. बहुत बढ़िया. Okay. Good. So we are building concepts also. Now, after PCT, let's come to the next important cell, which is thick ascending loop of Henle. Thick ascending loop of Henle. Now, in the thick ascending loop of Henle, on the luminal aspect, you have the all-important channel. You have the all-important channel, which is sodium-potassium 2-chloride channel, which is coded by the gene SLC12A1. SLC12A1. This is the gene, and yes, your favorite drug acts on this channel. What is the name of the drug which inhibits this channel and which can act as a diuretic? That drug is known as loop diuretic or furosemide. This is a furosemide or a loop diuretic. Okay? Good. Very good. Now, just try to please concentrate here. I'm going to teach you a very important concept. A very, very important concept. Now, मान लो this channel, just understand that this channel undergoes a loss of function mutation. So what will happen? Will sodium enter? Will sodium enter the blood? No. Will potassium enter the blood? No. All of them will be lost in urine. And with sodium, you know, water is also lost in the urine. So what will happen? You will have hyponatremia, hypokalemia, hypotension, and metabolic alkalosis. So if basically you develop a loss of function mutation of this disease, of this channel, you will develop hyponatremia, hypokalemia, hypotension, and metabolic alkalosis. Yes. Do you know which disease are we talking about? You heard a many number of times, but probably you don't remember it because you have not visualized it. And this disease is known as Barter's syndrome. This is known as Barter's syndrome. And the name of the channel is SLC12A1. SLC12A1. This is Barter's syndrome, which is characterized by hyponatremic, hypokalemic, metabolic alkalosis with hypotension. Superb. SLC12A1. Am I clear? Good. Now, just do one thing for me. I hope you've all made this cell. So basically, if you can see, there is a sodium potassium 2-chloride channel here. You have a potassium channel which is leading outside, which is a ROMK channel. Here you have a chloride channel, which is named as ClCnKb. And here you have a channel which is known as calcium sensing receptor. Okay? Just do me a favor. Just write for me 1, 2, 3, 4, 5 in anti-clockwise direction. Okay? 1, 2, 3, 4, 5. Sir, why have you made us write in this direction, sir? Any reason, sir? So what do I mean? One is mutation of SLC1 to A1, 2 is mutation of ROMK, 3 is mutation of CLC and KB, 4 is mutation of Barton, which is a subunit of CLC and KB, and 5 is mutation of calcium sensing receptor. Can you see this? Can you understand what I'm trying to say? So these 5, do you know what these 5 are? Life has become so easy for you. These 5 are 5 types of Bartter syndrome. These are 5 types of Bartter syndrome. So it has been asked previously in PGI Chandigarh and in AIMS exam about the types of Bartter. Now listen to me very carefully. PCT picture I will show you later on. I will show you later on, guys, okay? Try to concentrate what I am teaching you right now. Yes, let me zoom for you. I will wait for 2 seconds for you to see. Lot many requests are coming for zooming it. Swapna Lanka, I am giving you the answer. Do you have to remember all these, sir? Yes, I am giving you the answer. Beta dekho, if you are only asked about Barters, you will only about say SLC1 to A1. Do not go into the types. Just this is enough. And it is characterized by hyponatremic, hypokalemic, metabolic alkalosis with hypotension. But if you are asked about types of Bartter, only then will you have to remember all the 5. But yes, mostly in all India entrance exams, types are not entered into. But if you are targeting central institutes like AIMS, PGI and JIPMER, you have to. You have to, beta, you have to. There is no alternative. Because they do ask such difficult questions. Okay? And it is not that difficult because it is expected of you to remember in physiology the name of channel, and I have just incorporated medicine with physiology. Okay? What are you not able to write? What are you not able to understand? Tell me. Fourth one is the Bartin, B-A-R-T-I-N, which is a subunit of CLC and KB. Fifth is calcium sensing receptor. Okay. All right. What do you want me to clarify? Okay. Yes, super. Chalo. So now we have studied the names of the thick ascending loop of Henle, the drugs, the diseases and the channels. Now, coming to the distal convoluted tubule. Coming to the distal ROMK is renal outer medullary potassium channel, not required. Just remember ROMK. ROMK. Okay? Alright. Chalo. Okay? Now, say people are saying why alkalosis? This is a physiology concept. You know, potassium and hydrogen go hand in hand. If you lose excess of potassium distally for exchange of potassium, you lose a lot of acid. You lose a lot of proton. And when you lose proton, you will develop alkalosis. Is it clear now? Clear? Okay? Good. Now, quickly moving on to DCT. The distal convoluted tubule has on the lumen a very important channel, which is a sodium chloride channel, which is by the gene SLC12A3. If this gene is defective, mind you, which drug inhibits this channel? Come on, tell me, pharmacology champs. Which drug inhibits this channel? The drug is thiazide, which is a diuretic. So thiazide diuretic inhibits SLC12A3, which is a sodium chloride co-sympose channel on the luminal aspect of distal convoluted tubule. All right. Okay. Please draw the channel. Very simple channel. Very simple channel. I'm going very slow so that you can draw this also. Now, the sodium chloride channel, मान लो, if there is a loss of function mutation, will sodium be entered? No, sir. If sodium is not entered, what will be water loss? There will be loss of BP. Also, distally for exchange of sodium, you will lose potassium. And when you lose potassium, you develop metabolic alkalosis. So in short, you have developed the syndrome which is hyponatremic, hypokalemic, metabolic alkalosis with hypotension. So, do you know what this syndrome is known as? This syndrome is known as Gentleman syndrome. This syndrome is known as Gentleman syndrome. So a very brilliant guy told me, sir, both Parters and Gentlemans are demonstrated absolutely the same. Both are hyponatremic, hypokalemic, metabolic alkalosis. Yes. So both of them present with entirely the same clinical photograph. You are absolutely correct. How to differentiate, sir? I will tell you later on. Clear? I always tell my students, gentleman ko bolo, gentleman. It is kolo, gentleman. And barter ko bolo, barter. Why, sir? Because when you say gentleman, what syllable comes to your mind? It is T. T for thiazide. Thiazide for DCT. DCT for sodium chloride co-sympose. Hypokalemia beta, because when you lose sodium proximally, distally to save sodium, to the sodium potassium antipode, you will lose potassium also. समझ आया? Good. So this is known as Gentleman. So thiazide diuretics act on this channel, the loss of function mutation of which leads to Gentleman syndrome. Yeah, so I was saying Gentleman ko bolo Gentleman because T for thiazide. So a girl from Amritsar told me, sir, barter mein bhi to T hai. So I told her, beta barter ko bolo barter. So call it barter and call this Gentleman. If you do this, it's a very simple and lame process, but you are less likely to do any mistake. Okay? Okay? Good. Now, come to principal cell. I hope you are still remembering that page of mine where I taught you this. See, we were discussing this. We discussed PCT. We discussed loop of Henle. And now we discuss DCT. And now we are entering into the principal cell of cortical collecting duct. Okay? Yeah, the principal cell of cortical collecting duct. Now again the basic physiology. Yes, please draw this channel. It's a very simplistic diagram. No hi-fi drawing I am showing you. It's a very simple channel diagram. It takes hardly 2 minutes. Those who are feeling hungry, please continue to have your dinner along with the class. Okay? You have that luxury. This is the luxury of a live class, which is an online class, okay? Now this principal cell, if you remember the physiology, this is the cell on the lumen aspect. On the lumen aspect is a channel which is known as an intact channel. This is an intact channel or an epithelial sodium channel. And do you remember which channel, which drug inhibits this channel? Can you tell me, pharmacology champs? Can you tell me, pharmacology champions, which drug inhibits this channel? Yes, the drug which inhibits this channel is amiloride. It's a diuretic. It's a diuretic. Now, just understand what happens here. Intact channel says sodium enters inside the cell from the urine, and aldosterone is a hormone which acts, it's a mineralocorticoid, it acts on the mineralocorticoid receptor which is on the principal cell, and after acting on it, what happens is it stimulates sodium entry, stimulates potassium exit, and causes water to enter. So aldosterone, physiology say we have been studying, right from first year we have been studying functions of aldosterone. The functions of aldosterone are sodium water resorption and potassium secretion. Have we or have we not studied this? Yes, we have studied this. But how? We always used to mug it up. But today we have visualized this, that aldosterone will come, sodium water will enter, potassium will exit. Can you tell me that a drug which will inhibit the sodium and water entry by inhibiting the action of aldosterone and mineralocorticoid receptor? Can you tell me the name of this drug? Basically, I am asking you the aldosterone antagonist, which is spironolactone. Again, it is a diuretic. It is an aldosterone antagonist. It is an aldosterone antagonist, which is a diuretic that causes sodium and water to exit by not entering and potassium to not exit. So it basically causes hyperkalemia. We always call spironolactone as a potassium sparing diuretic. How, Anudeep? This is how. Okay. Now this was pharmacology. Now let us integrate medicine into it. If this channel undergoes a gain of function mutation, what will happen? Sir, all the sodium will enter here. Because the sodium will enter, you will have increased blood pressure. Because there will be increased blood pressure and increased sodium, ultimately it will lead to compensatory hypokalemia. And I have told you, hypokalemia, meaning low potassium, ultimately causes metabolic alkalosis. So this will lead to a syndrome where there will be hypernatremic hypokalemia and hypertension with metabolic alkalosis. And this syndrome, as many of you have correctly said to me, this is known as Liddle syndrome. नाम तो सुना होगा. Yes, you have correctly answered. Beautiful. Most of you are absolutely correct. So it leads to increased sodium, increased blood pressure, low potassium and metabolic alkalosis, which leads to Liddle syndrome because it is a gain of function. Mind you, it's a gain of function mutation. मतलब ज़्यादा functioning हो रहा है. So sodium enters more. With sodium also you enter water more. So ultimately there will be hypertension. And it will lead to compensatory hypokalemia and metabolic alkalosis. This is known as Little syndrome. GOF मतलब gain of function. Gain. Barter's was loss. Gentleman's was loss. Little is gain. Clear? Absolutely clear? Okay. MR का मतलब है mineralocorticoid receptor. Sabira Rafiq is asking, sir, how does hypokalemia occur here? See, more of sodium enters here, and you know sodium and potassium, there is a homeostasis in the entire tubule. So if more sodium enters here, ultimately in exchange in the distal collecting ducts, potassium will exit more, and that will lead to hypokalemia. Okay. Now, very important concept, please concentrate all of you. This aldosterone was acting on the mineralocorticoid receptor and causing sodium water to entry, potassium to exit. मान लो, if there is decreased activity or resistance to aldosterone, or resistance to function. Okay? Okay? So basically, if there is an aldosterone resistance, and if there is an aldosterone resistance or decreased activity of aldosterone, it will lead to a syndrome. It will lead to a syndrome which is known as renal tubular acidosis type 4. It is known as renal tubular acidosis type 4. Do not worry, I will teach it to you again. Just write it down here. It is known as renal tubular acidosis type 4, and please remember that because aldosterone did not act, so potassium did not get kicked out. Because potassium did not get kicked out, it will be characterized by hyperkalemia. It will be characterized by hyperkalemia. Okay? Good. So this is about the principal cell. I am halting for 2 seconds. Please write it down. Please write it down. Okay? Students, I can understand you are getting a bit overworked. This is the last class of the day. You have slogged the entire day, but beta, just remembered, this is not for me. I have happily passed that stage where you are still right now. Trust me, without hard effort, hard things are not achieved. If you want to achieve that which something which you have not done before, if you have achieved something which you have not got before, you have to do something which you have not done before. You have your duties tomorrow, so do I. I also work in a COVID ward, I see COVID patients, I wear PPE, I do all kinds of things which you do and probably more than you. But yes, still I want to teach you because I care for all of you and I want you to prosperously cross this exam. You know, this time will not come back again. Okay? So, please do not get overburdened. If you are, please take 3 deep breaths. Take 3 deep breaths, close your eyes, and just remember that smile on your parents' face which you want to be there when they first get to know that you have got your dream PG seat. For that smile, for that pride in your parents' face, please gear up again and continue. Okay? Okay, good. Chalo. So we have understood that RTA is a disorder characterized by aldosterone resistance or decreased activity of aldosterone. And why does hyperkalemia occur? Because potassium is not secreted out by ROMK. And why it is not secreted? Because aldosterone does not function. Clear? Still, if you have any doubt, you can message me, you can mail me later on. Plus, please do not get overworked with a one small query. Okay? Good. Now, come to alpha intercalated cell of cortical collecting duct. Please remember, alpha intercalated cell of cortical collecting duct, write down, it is the site of acidification of urine. Write down, physiology MCQ. Physiology MCQ is alpha intercalated cell is the site of acidification of urine. Bhai Rachit Bhandari has been behind me for answering me cola. What is cola? Let me tell you. Cola is cysteine, ornithine, lysine, arginine. Cola is cysteine, ornithine, lysine and arginine. Is it okay, Rachit Bhandari? Are you happy now? Please be, please be. I care for all of you. Okay? Now, sir, why do I call it the acidification site of urine? Because, sir, I told you that acid means proton, proton means acid. So, dekho, this is the urine lumen, jahan pe urine was coming, and just see, protons are secreted by two pumps. One is a proton pump, and one is an H plus K plus antipode. Both the form में H plus is secreted. You don't have to draw all this. You do not need to draw all this. Just draw this. Just draw this. This is enough for you. This is enough for you. Okay? So on the luminal aspect we have this channel which have two proton pumps. मान लो, if they do not function, there is a loss of function of this. So what will happen if there is a loss of function of this channel? There will be decreased secretion of acid in urine, which will lead to increased accumulation of acid in blood. When acid accumulates in blood, that is known as acidosis. Which organ are we studying? Kidney or liver? Sir, kidney. So this is renal acidosis. Which part of the renal, sir? It is a part of the duct, which is a continuation of the tubule. So it's basically a tubule. So this is known as renal tubular acidosis. This is renal tubular acidosis. Sir, which part of renal tubular acidosis? Sir, this is a distal renal tubular acidosis or RTA type 1, which is known as distal RTA. Which is known as distal RTA. Are you getting me? So, what is distal RTA, sir? Sir, I could have made you write in theory also distal RTA is loss of function of proton pumps in the alpha intercalated cells of cortical collecting duct, sir. But no. I have made you draw the figure because beta again I am telling you, mind thinks in figures. Develop a pictorial memory. Okay. Okay. Now quickly tell me by your basic knowledge, What will happen to potassium in distal RTA? What will happen to potassium in distal RTA? What will happen to potassium? The potassium was getting in the body from the urine. This potassium will not be entering the body from the urine. This potassium will not enter the body from the urine, so there will be loss of potassium, which will lead to hypokalemia. Which will lead to hypokalemia. I know, Abhishek Rana, you are super saturated, but your examiners and your exam will not listen to anything. I am not teaching you fast, I am teaching you concepts, I am not giving you information, blank information. I am giving you concepts. Please try to understand this, okay? So, type 1 is associated with hypokalemia. Type 4 is associated with hyperkalemia. I have made you write that. Am I correct? Yes, sir. Good. Are you good to go? Are you good to go ahead? No, Kaileshna, I am not doing emotional blackmail. Trust me, I care for you all and I want you to understand this very nicely. Okay? Yes, Vagmode, I am understanding you also. Good. So can we have a, how's the Josh? So how's the Josh? Hi, sir. Good. That's the spirit, that's the spirit. Okay? Now, after alpha intercalated cell after cortical collecting duct, come to medullary collecting duct. Come to medullary collecting duct. अब medullary collecting duct को एक story की तरह सुनो. Please try to listen to it as a story. What happened is there was a hormone which was known as antidiuretic hormone. That antidiuretic hormone acted on its receptor, and that receptor was known as V2 receptor, which was located on the basolateral aspect. On the basolateral aspect of the medullary collecting duct. ADH acted on this receptor, and what it did, it inserted aquaporin 2 channels. It inserted aquaporin 2. Where? On luminal aspect. तो बेसिकली ADH ने बंद दरवाजे खोल दिए. ADH ने बंद दरवाजे खोल दिए, and ADH acted on the V2 receptor, inserted aquaporin 2 channels, and the floodgates opened, and the water from the urine entered through this channel from the lumen and exited from the basolateral aspect through channels which is aquaporin 3 and aquaporin 4. The crux of the matter is aquaporin 2 is on the luminal aspect, aquaporin 3 and 4 are on the basolateral aspect. Physiology question है, anatomy question है, but देखो how it is important and relevant to nephromedicine also. Okay? Good. Most of you have a high Josh that it should be. Okay? Okay? Till our last breath we will go on fighting. That is the way. Nobody can make us lose our zest. We are very, very zestful. That's the spirit, guys. That's the spirit. I want this spirit to be maintained throughout the class. Now, quickly see here. What happens here? ADH acts on V2 receptor, inserts aquaporin 2, water enters through aquaporin 2 from the lumen and exits through aquaporin 3 and aquaporin 4. Okay? Now, मान लो if there is an excess of ADH, what will excess ADH do? Excess ADH will cause all the water from the urine inside the blood, all the water will be reabsorbed from aquaporin 2, 3 and 4 into the blood. And what will happen? What will happen? Urine will be very concentrated and will have less of water. Do you know what that situation is known as? Yes, you know that. You have heard of it. Probably you do not remember it right now. That is known as syndrome of inappropriate antidiuretic hormone excess. That is SIAD. So what is SIADH? SIADH means all the water from aquaporin 2, 3 and 4 reabsorb from urine into the blood. So urine has less water and blood has more water. Clear? Good. Now, if there is less of ADH, what will happen? The water will not be reabsorbed. If the water will not be reabsorbed, what will happen? All the water will be lost in the urine and the patient will go on peeing again and again and again. And that problem is known as diabetes insipidus. Diabetes 3 and 4 are on the basolateral aspect. Basolateral aspect. Okay? Okay? Yes. Yeah. Now, can you tell me the drug? Can you tell me the drug which will inhibit this receptor? Can you tell me the drug? SIADH means syndrome of inappropriate ADH excess. Syndrome of inappropriate ADH excess. Can you tell me the drug which will inhibit the V2 receptor? And that drug is known as tolvaptan, which is a V2 receptor antagonist. So, sir, why will we use this drug, sir? If you have a condition where excess of ADH is acting upon V2 receptor and reabsorbing all the water, and that is leading to concentrated urine and high water in the blood, if you can block this receptor, so ADH action is nullified. Yes, conviptan is also there. Conviptan is also there. Beta, desmopressin is nothing but synthetic ADH only. It's a congener of ADH, not an antagonist of ADH. I am asking about the antagonist. So basically, sir, tolvaptan is a drug which is used to treat what? It is used to treat. It is the treatment of choice of SIADH. So see how we have correlated endocrinology with nephrology and physiology also. Beta देखो what is SIAD? SIAD में what happened? All the water entered from the lumen into the urine and from the urinary lumen into the blood. So what happened in SIAD? There was decreased water in urine and increased water in blood. Okay, I am giving you the concept how SIAD is used to treat, I mean how tolvaptan is used to treat SIAD. Is it clear? Good. It's a V2 receptor antagonist. It's a basolateral, not bilateral. Okay? Good. Now, with this, we have more or less completed the basic physiology of nephrology, and I have tried to integrate it with all the necessary diseases, the medicine part, the biochemistry part, and everything. Okay? Now, before we begin the disease proper, let us begin the topic of how do nephrological diseases present. So what is the presentation of presenting clinical feature of nephrological diseases? What is the presenting clinical feature of nephrological diseases? Now, why will a patient come to a nephrologist? You must know that. Before we begin discussing the disease properly, you must know that how will they come to you? All the pictures that you are left remaining with, I will give it to you in the end, don't worry. How will this patient come to you? You must know this first. So it will come to you with number 1, altered urine output. What is the complaint and what is the significance of each presenting feature? So the patient will come to you with altered output. What do I mean by that? I mean the patient can have a oliguria, which means a urine output of less than 400 ml per day. The patient can have B, polyuria, or the patient can have C, anuria. Polyuria means more than 3 liters per day urine, and anuria means less than 100 ml per day urine. So oliguria, it could be oliguria, that is less than 400 ml per day. It could be polyuria, more than 3 liters per day, or it could be anuria, which is less than 100 ml per day. Now, what is the significance of oliguria? It is less of urine output. It's a very non-specific finding, and it can be found in any renal failure, acute or chronic. Polyuria could be found in many diseases. Many diseases are example of diabetic insipidus. Now, anuria. Please do not think anuria means no urine. Nahin, it means na ke barabar urine. So anuria, there are very few specific causes of anuria. What are they? The causes are number 1, bilateral renal artery obstruction, bilateral renal vein obstruction, bilateral renal outflow tract obstruction. Number 4, acute tubular necrosis. Acute tubular necrosis. Number 5, shock. Number 6, RPGN. RPGN. So the causes of anuria are very, very gruesome. They are very, very limited causes also. या तो all the arterial supply of the kidneys, both the kidneys are stopped, or both the venous drainage are stopped, or both the outflow tracts, that is say bilateral ureteral obstruction, or say the bladder, that is the common urinary tract, that is obstructed, or a patient has developed a severe acute tubular necrosis, or the patient is in absolute shock, so there is no blood supply to the kidney only, and last but not the least, the patient has developed a RPGN, that is a rapidly progressive glomerulonephritis, which is characterized by a crescentic type of glomerulonephritis in the kidney biopsy. So this is how these are the causes of anuria, and why I have written them in details is because this is an all India PG question. And somebody asked me, nephrotic syndrome is there polyuria? Not at all. There is not at all polyuria in nephrotic syndrome. Is it clear? Good. Now, after altered urine output, I think you have been able to write it along with me. Now, after altered urine output, what can the patient have next? The patient can have something which is known as frothy urine. Frothy urine, when the patient says, sir, if a patient is speaking in Hindi, he can say, sir, मेरे urine में झाग आ रहे हैं या फेना आ रहा है, as if it is the thing that appears when you how a soap lathers. So that frothy urine signifies proteinuria. It signifies proteinuria. Now, after frothy urine, a patient can also have reddish urine or cola colored urine. So a patient can have either frank blood that is reddish urine, or the patient can have an altered color which is a cola colored urine, and that is due to hematuria. That occurs in hematuria. So you have to understand the terminology of the patient. Why am I saying these words? Because patient will not come and tell you कि sir मुझे hematuria हो रहा है. Patient will tell you, sir, I am having a cola colored urine, or I am having a frothy urine. It is you who is intelligent, and you know how to understand or interpret the patient's complaints. Good. What else? The patient can have dysuria. Dys means pain or burning sensation or uncomfortable sensation. So that means it is burning during micturition. Okay, and dysuria, it is very, very significant of urinary tract infection. Urinary tract infection. Okay, signifies urinary tract infection. Okay. Now, patient can also present to a nephrologist with lower urinary tract symptoms, that is LUTS. Sir, what do I mean by that? What do I mean by lower urinary tract symptoms? Sir, it could mean urgency, frequency, precipitancy. Urgency means you have to immediately go, and when you get the urge, you cannot hold for a second. You have to go immediately. What do you mean by frequency? You have to go again and again. Precipitancy, before you might even reach the washroom, the patient may complain that, sir, there is urine in the urine has soiled my pants. Okay. Tell me significance. Where is it present? Tell me a disease present in benign prostate hypertrophy, BPH. It is present in benign prostate hypertrophy. After LUTS, let us discuss loin pain. After LUTS, let us discuss loin pain. After LUTS, let us discuss loin pain. Where is it present? Loin pain signifies it could be due to an infection of the kidney, pyelonephritis, or it is due to stones. It could be due to stones or pyelonephritis. Hesitancy can also be there in LUTS. Yes, hesitancy will also be there. You are absolutely correct. You can add hesitancy also. Please add hesitancy also. Next. Patient can present with a lump. Patient can sometimes say, sir, there is a swelling, sir, in my abdomen. Sir, there is an abdominal swelling, sir. What can it signify? It can be present where there are huge cysts in the kidney and they have led to a huge renal mass. That is, it can happen in autosomal dominant polycystic kidney disease. It can also happen in renal cell cancer, autosomal dominant polycystic kidney disease, or renal cell cancer. Okay. Now, what else? Patient can complain of swelling in the body, swelling in the body, which could mean what? Which could mean pedal edema, which could mean periorbital edema, or it could mean anasarca. Please tell me, my students, what do you mean by anasarca? What do you mean by anasarca? Anasarca means, you are correct, It means generalized edema. Swelling in the body can be very, very common in a patient of nephrotic syndrome. In a patient of nephrotic syndrome, ADPKD means autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. A patient can also have features like headache or something like that, and when on examination you found that the patient has hypertension. Hypertension is a very important presenting feature of a nephro disease, of a nephrological disease, and you know hypertension is characteristic of nephritic syndrome or chronic kidney disease. In nephritic syndrome or chronic kidney disease, after hypertension, the patient can have uremic clinical features. What do you mean by uremic clinical features? Sir, the patient can have anorexia, nausea, vomiting, weight loss, pruritus. What do you mean by uremia? Uremia means urea and emia. Urea increased in the blood. So due to increased urea in the blood, you can have uremia, which will have anorexia, nausea, vomiting, weight loss or pruritus, which is very significant in chronic kidney disease. So these are the very common nephrological complaints. These 10 are the very common nephrological complaints that a patient presents with to a nephrologist. What are they? They can be altered urine output. So they can be oliguria, less than 400 ml per day, polyuria, more than 3 liters per day, or anuria, less than 100 ml per day urine. Patient can have frothy urine, which is significant of proteinuria. Patient can have reddish urine or cola colored urine, which signifies hematuria. Patient can have dysuria, that is burning during micturition, which is significant of urinary tract infection. Patient can have lower urinary tract symptoms like hesitancy, frequency, urgency, precipitancy, which are very common in benign prostate hypertrophy. Patient can have a lumbar or a loin pain, which could signify stones or pyelonephritis. Patient can have a swelling, a lump, which could be due to autosomal dominant polycystic kidney disease, or a renal mass, which can be neoplastic. Patient can have a swelling of the body, which could be limited to the legs, that is pedal edema. It could have a periorbital swelling, or the patient can have an anasarca, very, very significant of nephrotic syndrome. Patient can have hypertension, that is increased BP, which signifies chronic kidney disease or nephritic syndrome. Very good. Or very commonly, if you have ever entered a nephro OPD, most of the patients are CKD patients, and most of them have non-specific complaints like, sir, bhook nahi lag rahi, sir, weight lose ho raha hai, sir, I'm having a lot of itching all over the body, sir, I'm having a vomiting sensation, I'm feeling very bad, sir, puking all the day, and you check the creatinine, and the creatinine turns out to be 4 or 5 or 6 or 7, and you immediately tell bad news to the patient that, sir or ma'am, you have a very bad disease which is known as chronic kidney disease. So these are the 10 very common presenting complaints to a nephrologist. Is it clear? Is it absolutely clear? Yes, ADPKD mein hypertension is seen. It is seen. What else? So today we have discussed the physiology in details. I have taught you the parts of the nephron formation. Beta, renal failure is a non-specific terminology. It includes both acute kidney injury and chronic kidney disease. But when I say chronic kidney disease, it means that the process has lasted for more than 3 months. Don't worry, I will teach it to you. Don't worry. Okay? Good. So, this is how we have discussed everything today about the physiology and how will a patient come to a nephrologist. So till now we have not entered any disease in proper, but we have discussed everything about the prelude of nephrology. So you are absolutely set now to discuss the nephrological disease proper. Do you want me to continue with the diseases now? Yes? Very good. Very good. I know you will be absolutely terrified if I do so. Now, some people do want a quick revision, which I am very glad to give now. Now, see, I told you these are the aorta, renal artery, interlobular artery, aortic artery, arcuate artery, which divides from the cortical radical artery, which forms the afferent arteriole, and afferent arteriole divides to form the glomerulus, and glomerulus continues to form the efferent arteriole. This is the urine. Renal plasma flow is 600 ml per minute. Ultimate glomerular filtration is 120 ml per minute, and urine formation is 1 ml per minute. Okay? Okay? Good. These are the 3 urinary processes. Now, very quickly then, I have already discussed the parts of nephron. The parts of nephron. Yes, come to this figure. Come to this figure. Please come to this figure. I told you this is the glomerulus. This is the afferent arteriole. This is the efferent arteriole. This is the afferent arteriole. This is the efferent arteriole dividing to form the glomerulus inside the Bowman's capsule. This is the macula densa, which is a part of the thick ascending loop of Henle in the same nephron. I am repeating it once more, and it mediates the tubuloglomerular feedback. Is it clear? Is it clear? Good. Now, just last thing, which I just forgot to mention in the initial part, was just a last bit. 5 minutes more I will take. That is auto-regulation. What happens is, if there is decreased blood pressure or if there is decreased glomerular filtration rate, what happens? It stimulates the renin release. It stimulates the renin release from JG apparatus, from JG cells. Now this renin, it converts angiotensin 1 to angiotensin 2. Angiotensin 2, you know, it is a vasoconstrictor and it constricts. If you can remember, यही तो वो दरवान था which was constricting the efferent arteriole. So it constricts the efferent arteriole. When the efferent arteriole constricts, you know that the exit gate constricts, so glomerular blood flow increases, and hence GFR increases. So just see here, your body had a low GFR or a low blood pressure or a low renal blood flow, but through renin release from the JG cells and angiotensin 2, you have increased the GFR. So basically, the kidney has auto-regulated itself to maintain the GFR. This is known as auto-regulation, meaning kidney saved itself. Kidney regulated itself against a low GFR. Okay? And how, after constricting efferent arteriole, what happens? I have already told you. And the last part, and the last 1 minute, say if the opposite happens. Say, I'm so sorry, this is angiotensinogen to angiotensin 1. Angiotensin 1 is converted by ACE to angiotensin 2, and angiotensin 2 constricts. I'm so sorry. Okay? I'm so sorry. You all were in so much of hurry that I also made a mistake. So it is the angiotensinogen that is converted to angiotensin 1 by the renin. Angiotensin 1 is converted to angiotensin 2 by ACE. And ACE converts to angiotensin 2. Angiotensin 2 is the efferent arterial vasoconstrictor, which increases the GFR. Now, what I was saying was, मान लो, if the opposite dense means there is hypercalciuria, that is why, Srijeta, there is trickets. Last but not the least, if there is increase in GFR, so if there is excess of GFR, what will happen? There will be increased sodium delivery in tubular fluid. When you have increased glomerular filtration, so more of sodium will enter into the tubular fluid. That tubular fluid ka sodium will be sensed by a sensory organ. You know, there is a sensory organ, I told you, very special sensory organ in the thick ascending loop of Henle. And what is that? It will be sensed by macula densa. And macula densa resides where? In thick ascending loop of Henle. I told you before. And when this macula densa will sense it, it will think, oh my God, my kidney is losing everything. If this is lost, what will I do? So let me protect it. What does it do? It secretes adenosine. And adenosine, what does it do? It constricts the afferent arteriole. So adenosine constricted the afferent arteriole, which was the entry gate. So my entry gate became narrow, so less of blood will enter. So decreases glomerular hydrostatic pressure and thus decreases GFR. So please see what you have done. There was a defect in the body, there was excess of GFR, excess of sodium delivery to the tubule. So it was sensed by macula densa, it narrowed the entry gate through adenosine and thus decreasing the GFR. Now the beauty of this process is, the beauty lies because the process started in the tubules, because it was sensed by the loop of Henle, and it ended where? In the glomerulus, because it constricted the afferent. Because it started in the tubules and ended in the glomerulus, this process is known as tubulo-glomerular feedback, which is known as TGF. So tubulo-glomerular feedback is a process which starts in the tubules through macula densa and which mediates adenosine mediated constriction of the afferent arteriole and thus decreasing the GFR. So it is a process that started in the tubules, ended in the glomerulus, and hence is known as tubulo-glomerular feedback. So see, with these two processes, one is through TGF and one is through renin-angiotensin-aldosterone system, one increases the GFR and one decreases the GFR, and hence the GFR is auto-regulated within a physiological range of BP divergence, and this is the best physiology of renal auto-regulation. Okay, I hope all of you have understood the concepts that I have tried to give you in details. I hope that, yes, I hope you have enjoyed learning. So have I. Enjoyed a lot teaching you guys. Tomorrow we shall enter the diseases in details. We will start with investigation of renal diseases and we shall enter into the other diseases in details. Okay, I would just like to end the day with a very famous and my favorite quotation by Steve Jobs, that is, stay hungry, stay foolish. Hungry as you all are and foolish as we all are also, but we fail to admit. But the day you take pride and admit that you are foolish and you know less, your receptivity will increase and you'll be receptive to every sense around you and you shall learn a lot more. Okay, cheers. Very sorry for holding you back for quite a long. Tomorrow also we shall have it till 10:30. Good night. Shabba khair. Have a tight sleep. Revise all the concepts. And tomorrow, please meet me with a lot more gusto, lot more zest, lot more excitement than today. Okay? Till then, I shall see you tomorrow. Thank you so much. Hmm.